All right. Is it everyone ready?
Yes.
Okay. Good morning, Dr. Desposito. I apologize in advance if some of these questions are a bit duplicative, but I intend to show this to the arbitrator, so um, there may be some overlap in the previous questions. Good morning, Dr. Desposito. What is your current professional title?
I am a distinguished professor of neuroscience and psychology at the University of California, Berkeley, and I'm an MD.
Are you a licensed physician in the state of California?
Yes.
Are you board certified in neurology?
Yes.
Can you briefly summarize your educational background, including your medical degree, residency training in neurology, and any subspecialty training relevant to brain injuries?
Yes, I did my medical training at SUNY Syracuse Medical Center. Then I did an internship in medicine at Nassau County Medical Center in New York, followed by a 3-year general neurology residency at Boston University um, School of Medicine. And then I did 2 years of clinical training at Boston University and also the Boston VA and the Brain Injury Rehab. And that was in the fields of cognitive neurology, traumatic brain injury, and neurorehabilitation.
Thank you. And how long have you been a professor of neuroscience and psychology at UC Berkeley?
25 years.
Okay. And before that, you're a professor in the Department of Neurology at the University of Pennsylvania School of Medicine. Is that
Yeah.
correct?
Yes.
Okay. And until just recently in 2023, you treated patients clinically at the VA hospital in Martinez?
Yes.
And did you have an opportunity to treat patients with mild traumatic brain injuries
Yes.
and diffuse axonal injuries, which may be a little overlap there?
Yes. That was a big part of my practice.
What type of neurological conditions did you typically diagnose and treat?
Since my specialty is cognitive behavioral neurology, any neurological disorder where the predominant deficit is cognitive or behavioral is the type of patients I saw. So, traumatic brain injury, stroke, and Alzheimer's, I would say, would be the top three.
Thank you. And have you been retained as an expert witness in legal matters from time to time?
Yes.
And if what percentage of your professional work is working on medical legal cases such as this one?
I don't know exactly, but I'd estimate less than 5% of my time.
Have you authored any books or peer-reviewed publications in the field of neurology or neuroscience?
Yes.
Approximately how many over the last 25 years?
I believe I have over 400 scientific publications and have written, I think, 6 books.
Wow. So you take this stuff pretty seriously, huh?
Yeah, it's my job.
Is it fair to say you've dedicated a fair portion of your life to the science of brain injuries?
Yes.
And you were also the director of the Henry H. Wheeler Jr. Brain Imaging Center at UC Berkeley. Is that true?
Yes, that's why I was recruited to Berkeley was to start a new imaging center. It was the first high field brain imaging center at a university without a medical school in the country.
So is it fair to say that you're up to date on the latest imaging techniques available to scientists to determine whether someone's sustained a diffuse axonal injury?
Yes.
And what is the best tool, the best imaging tool to detect a diffuse axonal injury as we sit here today in 2025?
Well, MRI scanning is the best tool we have, and there's two type of scans. There's one that can be done in the emergency room called susceptibility weighted imaging, which actually detects blood when an axon shears or tears. There's actually tears of blood vessel too, so it's actually picking up the blood uh, accumulation, not the actual tearing of the axons. And then after that, there's another type of imaging called diffuse tensor imaging, which is actually a direct measurement of the white matter pathways. It's been around for, it was discovered 30 years ago, so it's not a new technique.
Now, even with that advanced imaging, are all diffuse axonal injuries detectable on the imaging that we have?
Well, there's a categorization of traumatic brain injury, mild, moderate, severe, and it's fairly arbitrary. But what the field has accepted as mild is someone that has a loss of consciousness of less than 30 minutes, and if you've had loss of consciousness more than 30 minutes, it's considered a moderate or severe. So in that category of mild traumatic brain injury, most patients will not have any findings on MRI scan, that the scan does not have the spatial resolution to detect an injury to the axons. But if you were to do an autopsy on that patient, uh, even in someone who hasn't lost consciousness, you would see the injury to the axons.
Okay, and does MIS-CO fall into that category of mild traumatic brain injury where you wouldn't expect the diffuse axonal injury to appear on the imaging?
Yes,
Do you think that in the future we'll have machines that can detect even the sort of diffuse axonal injury that MIS-CO has?
I do. The part of the detection is the strength of the magnet. Currently in hospitals, we have a strength of magnet called 3 Tesla, and now companies such as Siemens, we have one of these at UC Berkeley, have a 7 Tesla magnet. So I think we will reach a point where we could detect axonal changes very similar to as if we were to do an autopsy.
Now, with the imaging available in this case, are you able to detect or rule out the presence of a diffuse axonal injury with MIS-CO?
No, the imaging that was done didn't detect a diffuse axonal injury, but it also does not rule it out.
And you've talked about the I think the strength of the magnets. Um, in layman's term, are is a diffuse axonal injury that MIS-CO has microscopic, such that it's just not currently detectable?
Yes, you can only see axons and brain cells under the microscope.
And we weren't able to do that with MIS-CO in this case because she's still using her brain. Is that fair to say?
Yes.
Okay. Can you explain how your combined expertise in clinical neurology, neuroscience research, and brain imaging provides a unique perspective on Miss Coe's traumatic brain injury, particularly in distinguishing her symptoms from age-related changes?
Yes, well, in the field of neurology, there are subspecialties, and so in most neurologists are general neurologists, where they treat many different kinds of neurological conditions, just like there's a general internist or family practitioner. But then there are neurologists that specialize in specific disorders like stroke or a traumatic brain injury or epilepsy. That would be similar to a pulmonologist or a cardiologist. And so the type of things that we are experts in as cognitive neurologists, specifically cognitive deficits, which we wouldn't expect a general neurologist to have expertise in. So being a cognitive neurologist, our bread and butter is the interpretation of cognitive testing. And so neuropsychological testing is very specific type of objective testing cognition, and that's our tool for our window into examining into understanding sort of the cognitive deficits. And I personally, because I'm an academic neurologist, I've trained many neuropsychologists over my career. So I think with that expertise, and then on top of the science of traumatic brain injury has evolved over time. There are many sort of old ideas that are still out there, like traumatic brain injury, everyone recovers in 3 months and things like that. Well, the science has moved on from those type of old thoughts, and so now we're learning more about sort of how often symptoms linger and what type of symptoms linger, and trying to understand why do some symptoms just don't go away. That's sort of the science behind it, which I'm very much involved in.
Thank you for that. Is a radiologist qualified to determine whether Miss Coe sustained a diffuse axonal injury based solely on her imaging results?
Well, if they see it, they certainly have expertise in detecting diffuse axonal injury from an MRI scan. If they see it, then yes, they will qualify to make the diagnosis of that. If they don't see it, then again, they can't they can't say that it's not diffuse axonal injury.
And why is that?
Again, because it's the whole idea of the absence of evidence is not evidence of absence. So the absence of any evidence that there's change in the MRI scan is not evidence that it doesn't exist. There still may be fish in the pond if you don't catch one.
And in your clinical practice, did you treat and help many patients who had diffuse axonal injuries that were not detectable on any modern MRI machine?
Yeah, I would say that it was rare that the MRI scan detected, diffuse axonal injury in the patients with mild traumatic brain injury that I was caring for.
Okay, so it's not just a novel thing that happens in some personal injury cases. It's sort of the reality of the current state of imaging. Is that fair to say?
Yeah, it's the norm, and it shouldn't be taken as evidence that there wasn't diffuse axonal injury.
And did you have an opportunity to meet with Miss Coe via Zoom on September 2nd, 2025?
Yes.
Okay. In preparing for your opinions in this case, did you review Miss Coe's medical records from before and after the September 25, 2023 collision, including the records from her primary care physician, Dr. Vanessa Wilson, and her general neurologist, Dr. Ravinder Kalan?
Yes.
And did you also have the opportunity to review the deposition testimony of her primary care physician, Dr. Wilson, and her brother, Joey Golau?
Yes.
Based on your extensive review of the records and your meeting with Ms. Coe, have you formed an opinion to a reasonable degree of medical probability as to whether she suffered an injury in the collision of September 25, 2023?
Yes, it was my opinion that she suffered a traumatic brain injury as a result of that accident.
And you also mention in your report a traumatic head injury. How is the traumatic head injury different from a traumatic brain injury?
Yeah, so when you have a accelerating force, or if you've banged your head, such as she did, obviously the head gets injured as well as the brain. So the important thing about the head is that you certainly can have a contusion, a soft tissue contusion, which often heals, but inside the head and before you get to the brain is the inner ear and the organs for balance. And so often our patients have damage to those, that you can think of it as a concussion to the auditory organ and the vestibular organ. That can also lead to symptoms such as ringing in the ears or tinnitus, or changes in balance and dizziness.
And ringing in the ears and challenges with dizziness, are those symptoms that Ms. Coe suffered from after the collision?
Yes.
Did she have some of those problems before the collision?
She did not have any documentation of the ringing in the ears. She did have what she described as dizziness that they thought was related to high blood pressure. One point I'd like to make about that is that patients use that word dizziness almost universally for any feeling that they have in their head. So often with high blood pressure, when someone's feeling, it's more of a lightheaded kind of feeling, but they'll still describe it as dizziness. With a traumatic brain injury, when they say dizziness, it's more of kind of a motion, kind of feeling off. Sometimes things are spinning, sometimes not, feeling off. And so the main characteristic of someone's lightheadedness, like for example, in her situation in the past, you wouldn't expect that to improve when you have vestibular therapy, for example. It's a separate mechanism, and certainly you wouldn't expect it to occur immediately after the accident.
Now, the deposition of Vanessa Wilson, she testified that there was unilateral sporadic tinnitus even before the collision. Can a rear end collision make a unilateral sporadic tinnitus become chronic and bilateral?
So I don't know what the mechanism would be for it. And again, tinnitus is also sort of a word that can mean different things. True tinnitus is a high-pitched, ringing sound. And so you wouldn't you and a brain and again, it's not only just due to the organ in the head, it's also the brain. It's sort of the injury to the brain that does it as well. So that's why it's kind of bilateral as opposed to just on one side. But if someone did have sort of tinnitus for some other reason, it's possible that traumatic brain injury can exacerbate the condition.
In your expert opinion, what was the mechanism of Miss Coe's traumatic brain injury in this collision?
By definition, a traumatic brain injury, or some people use the term concussion synonymously, they're the same thing. There is only one mechanism, and that is diffuse axonal injury. There is not another cause for neurological symptoms that is not diffuse axonal injury.
And in layman's terms, what is a diffuse axonal injury?
It just means that when you've hit your head and your head undergoes a significant angular force where it sort of violently goes forward and backwards, the axons, which are the nerve fibers in the brain, they can stretch and then they compress and they can actually tear. And so if they stretch, if there's just like an electrical cable, if you kind of stretch it, it can lose its ability to transmit those impulses. So just even if it's not teared, it can not function properly. If it tears, of course, it's not going to function properly and it's not going to regrow. Some people's recovery, we think, is because of that kind of just stretching, somehow that it sort of reorganizes itself if it doesn't tear. So that's what happens in everyone that's suffered a concussion, and it's just a different level of degree from more mild to more severe cases.
And when an axon is stretched, compressed, or torn, does that affect the brain signal and lead to symptoms?
Right. So all of when you tear, when you have this stretching, the axons actually in the frontal lobes are the ones that are kind of the ones that are important for sort of the executive function and memory, are the parts of the brain that are most affected. And so it doesn't let those areas communicate. So you get symptoms like not able to sort of, consolidate and learn new information and being forgetful. And that's why other parts of the brain, the axons are not being torn. So that's why you can speak articulately, you can be oriented, you don't forget what the year is or what your name is. You don't forget information that's stored in the other part of the brain. There's a lot of abilities that are not affected because those axons are not torn. So that's why there's this misconception that someone that's sounding sort of articulate at the scene, has not suffered shearing of axons. They have. They just are shearing axons that haven't been, tested at the scene.
Did Miss Coe's age and pre-existing medical conditions make her more susceptible to sustaining a significant and persistent traumatic brain injury from the forces involved in this collision?
Yes, my experience and experience of others in the field is that the older you are, the worse you do after concussion. So, a 20-year-old with an equivalent concussion to a 7-year-old, the outcomes are often quite different. So you're more likely to have persistent symptoms the older you are when you suffer your traumatic brain injury.
Have you reviewed slides that help illustrate your opinion about how forces from a rear end collision can cause a diffuse axonal injury?
Yes.
Okay, well, why don't we go over those slides now and see if you can explain some of your opinions. Let me see. Is everyone able to see the claimant in this case, Miss Coe, on the slideshow?
Yes.
Okay, great. Were you able to review property damages? I'm sorry, property damage photos of the collision in this case?
Yes.
And what do those tell you about the forces in this collision?
Well, in combination with the estimated speed of both the vehicles and just looking at the vehicles, it would be my opinion that there was significant force to cause a diffuse axonal injury.
What happens to the head following a high-speed rear-end collision?
Well, it very commonly occurs, in accidents. And the counterintuitive thing is not always does someone actually hit their head on the dashboard or the headrest. You don't need to have a direct impact on the brain to have a diffuse axonal injury. In fact, most cases there isn't a direct impact. So, but if there is, it sends, whether it's a direct impact, as this slide is showing, or if it's just the force of coming to a stop very quickly, the brain in the skull kind of moves forward very violently and then reaches, about a block at the skull and then goes sort of backwards.
So can that explain how someone who sustained a hematoma in the back of their head appears to be having problems associated with the frontal lobe?
Yeah, so you can have a injury, a direct bruise to the brain directly where the impact is, and you can also have it on the opposite to that because of what they call the contre-coup injury, because of the brain being sent forward.
And have you reviewed the photographs of the scalp hematoma on the back of Miss Coe's head?
Yes.
What's the significance of the fact that she had a hematoma on the back of her head immediately following the collision?
Well, it's just indication that there was an impact of her skull from the car accident.
So we're looking at an illustration of a normal axon. What's the function of an axon in the frontal lobe?
Well, a normal brain cell, which is on the right, has a cell body, and the signal is generated in that cell body, and then it goes down. It's sent down the axon in order to communicate with the next brain cell. And so there's billions of brain cells that are connected with each other and form a network. And those the way they communicate is by transmitting this electrical signal, down the axon.
Now, I'm going to show you a video, and I'm hoping that you can explain using this video how axons can be damaged following trauma from a rear end collision. Let me pause right there.
Yeah, yeah. So that was a good illustration how the axon that normally has a certain orientation gets stretched or bent or torn, or and so it doesn't have to be completely torn. It can just be bent or compressed or stretched. And so there's signals that are going through it. And so that this is just sort of showing that after that happens, now the signals are blocked from going down in a precise way. And then it obviously can't communicate with the next the next brain cell properly. And this would be an example where obviously if it's completely torn, uh, it's not going to transmit any signal. And the important point to make is that axon does not grow back.
Can we tell one way or the other whether in Miss Coe's concussion and diffuse axonal injury, whether some of the neurons were torn or whether they were just stretched and or compressed?
No, we don't have any imaging that could distinguish that. What diffusion tensor imaging does, though, if you do it sort of in the chronic state a year later, it can detect that there's less axons, in one side of the brain than the other, and that we infer from that those axons have been completely torn and have not reestablished connections.
And can you explain this slide and how it's useful in illustrating your opinion about Miss Coe's diffuse axonal injury?
Yeah, I think the top two slides here is just an example of how if you take a cable or wire and you can, if it goes in on itself and compresses, that can injure everything inside it. Or if you kind of pull it apart, you can actually injure what's inside that axon. So those are two different mechanisms by which what's inside that axon can be damaged. And of course, if there's enough of a shearing force where it tears, then I think it's obvious that there's not going to be any communication of that signal.
Okay. And so compression, tension, and shearing forces, do those all disrupt the signal coming from an axon?
Yes, and we believe that some of the recovery is from the compressed and the top two mechanisms that have potential for recovery, not always, whereas the bottom mechanism has no potential for recovery.
And what sort of symptoms can a diffuse axonal injury cause in any person, not just Miss Coe?
Yeah, like I said, it happens to be the longest axons in the brain that are affected. So these are the axons that are emanating from the frontal lobes. So the frontal lobes are important for executive function, for attention, for multitasking, for working memory. So those are the type of cognitive deficits that we see, and it's a very specific pattern. Whereas there's many preserved abilities. So our language remains perfectly intact. Our visual spatials perfectly intact, our visual processing. And so just like on the neuropsych testing that she had, there were many abilities that were perfectly fine. And so these are very specific. It's very specific to where the actual diffuse axonal injury occurs.
Thank you. What symptoms did Miss Coe's diffuse axonal injury cause?
Well, both in what she was describing as being forgetful, and having just not processing information as fast, having trouble doing, a couple to tasks at the same time, staying focused. These are all the type of symptoms that we hear about in our patients, and they line up with the type of tests that were done in the neuropsychological testing. By Dr. Wilson and Dr. Anderson that were specifically focused on testing those abilities that she was complaining of.
Did the presentation of those symptoms arise gradually, or based on your review of the records, was there an abrupt escalation and creation of new symptoms following the motor vehicle collision?
I mean, based on my history, based on the history of her primary care physician, and based on the history of a neurologist, we all got the history that these symptoms occurred suddenly, occurred after her accident, and were not present before the accident, and that's why we all made the diagnosis of a traumatic brain injury and not a pre-existing condition.
Does a person need to lose consciousness to sustain a diffuse axonal injury?
No, absolutely not. That's another one of these old thoughts that I said science has disproven. The other one was that everyone recovers in a couple of months. The other one that science has proven over and over again is that you don't need to lose consciousness to suffer diffuse axonal injury. There's been studies where there has been an autopsy in an individual that's died of some other cause that didn't lose consciousness, that had diffuse axonal on the microscopically. So it's absolutely been established that you can have diffuse axonal injury with loss of consciousness. And for some reason, the focus on loss of consciousness still seems to be something that EMT and ear doctors seem to be focused on, but it's not evidence that patient has not had diffuse axonal injury.
What is anterograde amnesia?
Yeah, anterograde amnesia is probably the most important symptom. If I was worked as an EMT or in the ER, that's the symptom that I would really focus in on. What it means is your ability to learn new information and to lay down new memories. So at the time of the accident, from that point on, are you registering new information? So if you have a patient that has a history where they remember being hit like she did, and then the next thing she's doing is talking to someone about it in the car, and that 30 seconds or a minute is gone, that means that she didn't lay down any information during that time. And then if you were to ask her to learn new information, which no one did in the EMT or the emergency room doctor, if you said, I want you to remember these 5 words: cat, apple, table, purple, bank, I guarantee you she would not remember any of those words a minute later. And that's why, that's why we've evolved into, with athletes coming off the football field, is that's what you need to do. You need to see if they have an anterograde amnesia, if they can't learn new information. Because if you just ask them about information that they've learned previously, like what year it is and what's the name of your team and are we playing football today, they're going to answer that correctly. And that's why so many athletes were sent back onto the field. But if you now off the field, like the NFL does, say, remember for me, I won't tell me, hold on these words: cat, apple, purple, bank, and they can't remember them, they're not going back into the game. So this doesn't happen. The EMT didn't do that. The ER didn't do that. So we don't know. We don't know we don't know sort of what the level of anterograde amnesia was at the scene.
Does the evidence show that Miss Coe had anterograde amnesia at the scene?
I mean, I would say yes, based on the history that she gave me, and so that she does not have a memory between the time she was hit and afterwards, and also that the details of the ambulance ride and being in the ER, this is very typical when the patients sort of have a vague memory as opposed to a crystal clear memory of it. That's what I mean by anterograde. She wasn't laying down new memories during that time period. So when you ask her 6 months later or a year later, they're not there. They were never laid down.
And is that lack of recall evidence of disruption to axons?
Yeah, that's exactly how a diffuse axon expresses itself. It expresses itself by not being able to create the right, you don't have the signaling to sort of lay down memories, and also this mental fogginess that the patients complain of. They're not just, again, have the sort of information processing capabilities, sort of pay attention, focus, and not get distracted.
Are the persistent symptoms Ms. Coe has reported since the collision, including dizziness, headaches, tinnitus, memory problems, difficulty focusing, are those consistent with a diagnosis of traumatic brain injury caused by a diffuse axonal injury?
Absolutely. These are the textbook symptoms of um, of what of what someone has after a traumatic brain injury, and that's why we ask those specific symptoms as opposed to other neurological. There's a lot of neurological symptoms we can ask about, and the ones we ask about are the ones that we see after a concussion.
Now, Miss Coe's primary care physician, Dr. Vanessa Wilson, who treated her years before the collision, testified that Miss Coe's significant cognitive problems were a new problem after the accident and had a clear temporal relationship to that head trauma. As a neurologist, how critical is the temporal connection in establishing causation to a reasonable degree of medical probability?
Well, it's absolutely critical. I mean, that's the point of taking a history, that you have to a cause and effect is determined based on the time course of the illness. In fact, we learned in neurology residency that history is often more important than the neurological exam in making a diagnosis. So whether something comes on slow or something comes on suddenly. So we both got the history that these symptoms were new after the accident, and there wasn't a pre-existing condition that could explain sort of why there were these symptoms after the accident.
Does that temporal relationship of new cognitive symptoms help you distinguish the cause of her deficits from being caused by cerebral vessel disease?
Yeah, absolutely. I think if someone is developing cognitive impairment, it gradually it occurs and then it gradually worsens over time. And there's no in the normal aging process or the type of cognitive deficits we see with high blood pressure. It's kind of a slow decline over many years, and it doesn't have a sudden change. There isn't one day where they wake up and suddenly they're having a lot of problems. So that just doesn't happen. So there has to be another if someone has a new worsening of their symptoms, something happened to them. They had a stroke, they had a head injury, something happened, but it isn't the sort of just normal process of high blood pressure and getting older.
In this case, based on everything that you've reviewed, is there any more likely medical explanation for the onset and presentation of her neurological symptoms at the time, other than a traumatic brain injury and head injury caused by the accident on September 25th, 2023?
Not in my opinion, and I just want to reiterate that her treating primary care physician and treating neurologist has the same opinion.
Did Miss Coe have any pre-existing medical conditions before the accident on September 25th, 2023 that could reasonably have caused these new neurological deficits?
No.
And have we discussed the reasons why?
Yes.
Okay. In your opinion, did the forces of the collision also cause a cochlear and labyrinthine concussion, damaging the structures in her inner ear?
Yes.
Can you explain to the arbitrator how such an injury would directly cause her persistent symptoms of bilateral tinnitus and dizziness?
Well, like I said before, the inner ear has two organs. One is the auditory organ for hearing, and the other one is the vestibular organ for balance. And then those organs have connections into the brain, and there's areas of the brain that are important for hearing and balance as well. So they're a tightly interconnected system. So it's difficult. So both the direct impact onto these organs can be concussed just like the brain can be concussed. So often it's a combination of both that's contributing to the persistent symptoms. It's very hard when someone has persistent tinnitus or persistent vestibular problems, it's very hard to distinguish how much is coming from the organ was damaged versus how much was the brain damage because they're so tightly connected. So the best opinion I can give is that it's a contribution from that both have been injured.
How do the results of neuropsychological testing performed by Dr. Wilson and Dr. Henderson support your opinion that Ms. Coe's impairments in executive function and working memory are consistent with a TBI?
Well, as I said, there's many different parts of the brain that contribute to different cognitive abilities. There's five main cognitive abilities: attention, memory, executive function, language skills, and visual spatial skills. And head injury doesn't affect all of them. It affects only some of them in a very specific pattern. It tends to affect attention, memory, and executive function, and not impact language abilities and visual spatial abilities. And that was the finding on both the testing. There was many preserved abilities that you wouldn't expect in a traumatic brain injury. And so both the neuropsych testing were very consistent with each other and consistent with the pattern and clinical profile that we see in patients with a traumatic brain injury.
If I understand that, are you saying that the cognitive areas that are most sensitive to traumatic brain injury correlate with the areas of testing that she did the most poorly on?
Yes.
You've noted impairments in executive function. Is that sort of impairment consistent with her brother Joey's report that she had to stop driving long distances because she would get lost?
Yeah, a lot of times patients kind of describe their problem as a memory problem. And you know, they always say they're forgetful, and sometimes they are forgetful, but when you test them, it's not really their memory. It's the way they're sort of accessing information, which we call executive function, is the way they kind of attend to what's relevant and what's not relevant, the way they're able to inhibit information that's not, you know, not necessary. And so it's these executive problems that can lead to problems when you try to do any type of daily activity. I think she told me that she was having trouble with cooking, you know, or even showering. These are the type of things that's simple to us, but when you think about cooking, it involves goals and sub goals, and you've got to plan different, you know, just to make a sandwich, you've got to plan it out, or make a meal, you have to sort of plan it and think ahead and then think back and multitask. And those are the type of that seemingly simple tasks become difficult. So what she was describing, what her brother was describing, what she told her treating physicians is all consistent with what was found on neuropsychological testing.
Dr. Wilson, Ms. Coe's primary care physician, testified that her increased dizziness contributed to her fall and subsequent hip fracture in December of 2024. As a neurologist, do you agree that persistent dizziness is a known and foreseeable consequence of a traumatic brain injury like the one Ms. Coe sustained?
Yes, it's one of the most common persistent symptoms.
Let's talk about some of the defense experts for a little bit before we conclude. Dr. Henderson, another expert in this case, has given the opinion that Ms. Coe's cognitive issues are due to factors like aging and emotional distress, not a TBI. Based on your expertise and findings of meeting with Ms. Coe, why do you disagree with that?
Well, first of all, what we talked about is the temporal course is very important. So I don't believe that on September 25th of 23 that she suddenly became more anxious and more depressed and for no reason. That the time course is consistent with that. There was a cause of that increase in changes in her emotional state, and that, in my opinion, was caused by the traumatic brain injury. Second is I would agree that all of our patients become more anxious and depressed and upset and frustrated when they're cognitively not thinking well. I mean, we've all had the experience of being sick, having a bad flu and just not being able to think clearly, and it's very frustrating. It's very frustrating, and it gets us down. And so that will certainly contribute to the cognitive symptoms. It doesn't make things better; it only makes things worse. But it's not the cause of the cognitive symptoms. And when you get better of the flu, your cognitive symptoms, will get better. But when you've had a diffuse axonal injury and you've torn axons, when you feel better or sleep better, it doesn't get any better, and that's what makes it so frustrating to patients, that even on good days they don't feel cognitively well.
Can changes in cognition from a diffuse axonal injury be an actual source of emotional distress?
I mean, I think that is the source. I mean, there's some evidence that the injury. I mean, emotion comes from the brain. It doesn't come from the spirit. We express, anxiety and stress and depression from the brain. It doesn't come from the liver, the kidney. So the brain is. So you can have injuries that directly, where the injury itself is causing the emotional difficulties. So we have had patients where cognitively they're quite well, but they're emotionally impaired because of the injury. But most instances, it's secondary to the cognitive deficits. It's someone who was high functioning that now is just not clear, and secondarily sort of gets. It reacts to it and deals with it with feeling down, frustrated, anxious.
Is hypertension the principal source of Miss Coe's cognitive deficits that we've seen on neuropsychological testing?
No, I mean, she didn't have any evidence she had hypertension before the accident, and she didn't have any cognitive deficits. And like I said, in patients that develop cognitive deficits, it's slow, it's over time, it's not to the extent that was found on this testing, and it doesn't come on suddenly.
Assume that hypertension is one of the sources of Miss Coe's cognitive deficits. Would you be able to quantify how much hypertension contributes to her cognitive deficits as compared to the TBI in any meaningful way?
Well, it's not the hypertension itself. It's the effect of hypertension on the brain. So what the hypertension does is it leads to not enough blood flow to the brain. So you develop these small micro infarcts, and that's what was seen on her MRI scan, and it was described as being mild. So it wasn't a severe amount of change. And so in my experience, almost everyone has that age with hypertension has an MRI scan that looks like that and is perfectly fine. So you wouldn't expect that to have caused any significant cognitive deficits.
Is there any evidence in this case that Miss Coe um, was getting lost while driving to familiar places such as Walmart before this crash?
No, I think, from what I read from the deposition of her brother, this was a new experience for him and her.
Oh, is Miss Coe's neuropsychological testing results consistent with anxiety being the cause of her cognitive deficits?
No, it's not the typical pattern that we see. It is true that anxiety can cause people to have executive difficulty, but typically on the testing, it's not as specific of a profile as that. They tend to have more trouble across all the domains, right? If you're anxious, then you'll have difficulty on almost every test you're given. There'd be no reason why you would do well on one test and suddenly not happen to be anxious during those 15 minutes, and then another 10 minutes be anxious on some tests. You wouldn't know, like, which test you're supposed to be anxious or not anxious for. So typically you're just anxious all the time, right? So it should sort of affect it across the board. And so that's not the kind of findings on that either neuropsychologist found.
If Miss Coe does everything she can to treat and eliminate her anxiety, um, to the extent that that's possible, will her cognitive deficit simply go away?
I don't believe so. One of the most frustrating things in my practice has been in the rare instances that we have been able to decrease someone's anxiety, or we've been able to get them to sleep better, or we've gotten rid of their headaches completely. They still have the cognitive deficits, and that's what is most frustrating. And sort of a corollary to this is the other thing that's extremely frustrating is that it seems to be assumed by many clinicians that these are easy things to treat. Well, they are not. Anxiety after a head injury, sleep disorder after a head injury, and headaches are very difficult to treat. I wish there was some magic to sort of it simply going away. But so on the one hand, they're very difficult to treat. So I think it really trivializes sort of the issue when you say that we'll just treat it and everything will, and everything will get better. Well, that's easier said than done. And then, like I said, even if there was that magic potion to get rid of all these things, the cognition, axons don't regrow. The cognitive abilities she'd still have difficulties cognitively.
Is there any current research or science into regrowing axons?
There's a lot of science, and it's just been proven over and over again that you can't get axons to regrow. There's been some real breakthroughs to be able to do it peripherally, like in the spinal cord and severed a nerve in your arm, because that's an easier task to just get an axon from your neck to your finger to regrow. But in the brain, because there's so much, it's so complicated, the connections that have to regrow, we're all wondering whether that's part of the brain's defense against not having misfiring, miswiring that we kind of prevent. There's actually chemicals in the brain that prevent rewiring, because I think the brain does not want to would rather find other routes than to rewire incorrectly, if that makes sense.
That does make sense. Thank you. Uh, Dr. Desposito, the defense recently retained a radiologist to interpret Ms. Coe's brain scans. We've touched on this a little bit, but I want to be crystal clear. Assume that the defense radiologist concludes that there was no brain injury in Ms. Coe's case due to the negative scans. As a neurologist specializing in brain injury, why can a radiologist relying solely on these standard scans not definitively rule out a diffuse axonal injury in Ms. Coe's case?
Objection, lacks foundation and calls for speculation.
Well, I would say that there isn't any a radiologist cannot conclude that there has not been diffuse axonal injury from the scan, from a scan, for the reasons we went over, that it doesn't have the spatial resolution to detect. No more than someone fishing in a pond who doesn't catch a fish can conclude that there's no fish in the pond. It's really the same thing. So certainly a radiologist absolutely can opine that there's no evidence for diffuse axonal injury on that scan, but not that there's no evidence that diffuse axonal injury hasn't occurred.
Last question on this subject, and then I'll move on. Does a radiologist's report of no acute intracranial abnormality mean that no injury to the brain's function has occurred?
No.
And we've discussed the reasons why, correct?
Yes.
You've reviewed the report of Dr. Chitra Venkatasubramanian, who concludes Ms. Coe's residual complaints are the result of untreated anxiety. How do you respond to that opinion based on your evaluation and expertise?
Well, I kind of answered this before. I think I don't believe that anxiety can explain all of the symptoms that she has. So we talked a lot about the cognitive symptoms of why the neuropsychological profile is not consistent with the with the diagnosis of anxiety only. I think that's pretty clear difference. So I don't think there's a good explanation of how anxiety can explain that neuropsychological profile. It also does explain the other symptoms of traumatic brain injury. She has other symptoms that we talked about, like dizziness and ringing in the ear and headaches. And so this is kind of an explanation that explains some of the symptoms, but not all the symptoms. I certainly don't think they're going to find that they would think that a ringing in your ear is going to go away with anxiety being treated, or dizziness is going to go away. So I don't understand how it kind of is trying to explain part of the brain injury, but not the other part.
Dr. Kalon, a general neurologist, testified that she distinguishes between post-concussion syndrome and TBI based on the severity of impact. As a neurologist specializing in cognitive neuroscience and brain injury, do you agree with that distinction?
No, I do hear that from general neurologists that there's something different about post-concussion than traumatic brain injury. By definition, post-concussion means that someone had a concussion, and a concussion is synonymous with traumatic brain injury. So there's no logical sense to how a post-concussion can be different from a traumatic brain injury. So even if we were to believe that concussion is something different than traumatic brain injury, there would have to be a mechanism for why the patient had neurological symptoms. What I'm saying is that the cause of the neurological symptoms of traumatic brain injury is shearing of axons or tearing of axons. If someone believes that concussion is something different, I'd like to hear what the mechanism is that caused the neurological symptoms. It doesn't come from the spirits. There has to be something, just like when you sprain your ankle, it's caused by a ligament tear. So I think the problem with that sort of idea that concussion is something that is, it doesn't explain what caused the neurological symptoms.
So I take it that that's not generally accepted in the field of neuroscience and cognitive behavioral research, that there's a distinction between post-concussive syndrome and traumatic brain injury.
No, it really should be post-traumatic brain injury syndrome. We should really get rid of the word concussion, in my opinion, because I think the confusion is that general neurologists and other clinicians view concussion as something very mild that doesn't have that always recovers, which is just not true.
Okay, moving on to the prognosis of Ms. Coe. You've noted that Ms. Coe continues to experience neurological and behavioral deficits more than a year after the accident. I think we're more than 2 years after the accident now. What is your opinion to a reasonable degree of medical probability regarding her prognosis for a full recovery from her symptoms?
Yeah, it's my opinion that she's not going to make any recovery from the symptoms she's had, from the cognitive symptoms that she has now. There's no magic time. A year has been in all the studies that have been done. A year is a pretty good estimate that most patients after a year, it's unlikely that they're going to make a recovery. And the further you get along, now we're at 2 years, that it's even less likely. So in my experience, I haven't seen a patient like her 2 years out that have any recovery. What we do see sometimes is people learn to cope better with their deficits. That's different than axons recovering. That there's no chance of any of her axons regrowing to lead to a resolution of her cognitive symptoms.
And is that her best hope, that she learns techniques to better cope with her deficits?
Yeah, that's the only thing. And like we talked about before, some improvement in dizziness and anxiety and sleep, which are very difficult to treat, can help somewhat as well.
Now, while there's a potential for some improvement, she also continues to age. how will Miss Coe's symptoms progress and affect her quality of life over the next 10 years?
Well, that's the problem. I mean, we all over time slow down. Our information processing slows down. We have trouble remembering, coming up with words. We all get forgetful. That's just sort of a natural process. Some people it's very slow. Some people it's faster. And whatever that trajectory is, after you've had a concussion, that trajectory now gets steepened, and so it changes the trajectory of that. So whatever her trajectory was for aging, it's now going to be faster.
The testimony from Miss Coe and her family describes significant changes in her daily functioning, such as getting lost while driving, leaving the stove on, and essentially becoming more and more dependent on her brother. Are these functional declines consistent with the impairments in executive function and memory you would expect from the type of traumatic brain injury Miss Coe sustained?
Yes.
Is Miss Coe at risk of experiencing worsening cognitive function if she suffers another traumatic brain injury?
Yes, there's a accumulation. Anyone who's had a traumatic brain injury is at increase of worsening outcome prognosis after a second head injury.
Does Miss Coe face a greater risk of developing declining cognitive function or dementia as she ages compared to someone who has not experienced a traumatic brain injury?
Yes, there's been a lot of research on the relationship between head injury and developing dementia and Alzheimer's disease, and there's a strong relationship between the two. So anyone who's had a brain injury at any point in their life is at increased risk of developing dementia or Alzheimer's later in life.
Thank you very much, Dr. Deposito. I have no further questions at this time.
Okay.
Thank you, Doctor. Madam Reporter, is there anything you need to put on the record?
No, but I need some clarification since we're off the record. Thank you.
And I would ask that I need the transcript to be expedited. Can that be done?
Can we discuss that afterwards? I just need to check the workload and how long the
Sure.
deposition transcript is. Thank you.
All right. Are we off the record then?
Before we conclude, I need to get video orders on the record as well. Mr. Roach, did you want a video copy of today's deposition?
Yes, please. Hopefully within roughly a week, if that's possible.
Okay. And did you want that synced or standard copy?
Standard copy's fine.
Okay. Mr. Anderson, did you want your copy synced or standard?
No, I don't want to order one now. Just send me your contact information.
I'm sorry, Peyton. Let me get it synced. I want to sync this.
Okay. Perfect. Sounds good. All right. In that case, this concludes the videotape deposition of Mark Deposito, MD. The time is 12:39 p.m. and we are off the record.